Well, hello and welcome back to the Center for Digital Health Research podcast. I am your host, Pierre Ducharme Gauthier. Throughout our episodes, we'll discuss novel, transformative research in the realm of digital health, chat with an expert in a related field, or introduce you to useful online platforms and technologies to keep an eye on. So we have a special guest here today, Dr. Anthony Levinson. Hi, how are you?
I'm doing really well. Thanks for having me today.
Awesome. It's a pleasure to have you here. So, Dr. Anthony Levinson is a psychiatrist and professor at McMaster University, where he holds the Johns R. Evans Chair in Health Sciences, Educational Research, and Instructional Development. He leads work in e-learning innovation with a focus on designing and evaluating evidence-based digital education for health professionals, older adults, care partners, and the public. His work includes aging-related resources such as iGeriCare and e-learning sessions and videos connected with the McMaster Optimal Aging Portal. Yeah. First of all, is there kind of any background that you could talk about, kind of what your educational background was like?
My background actually, I studied English literature and philosophy and worked for a bit doing critical theory before switching into medicine and have done extra research training in neuropsychiatry and clinical research methods and educational research. Um, and I would say maybe over 25 years as being the lead for implementation of online curriculum within the undergraduate MD program at McMaster University,
Wow.
and have literally developed probably hundreds of online educational resources for med students, physicians in practice, allied health, and increasingly for the general public, family, friend, care partners, older adults. So yeah, been at this for a long time. So I have a pretty practical perspective about how one can design, develop, implement e-learning at scale.
That's wonderful. Would you say then, like your English background or your background in arts really helped you with kind of the e-learning aspect of your kind of career and where you wanted to go into?
Yeah, that's an interesting question. I think there is in online learning, in the design of education for different audience, an appreciation of narrative and stories is very important. I think that's maybe one of the ways. Obviously, there's a fair amount of communication skills involved in translating information for different audiences. So
Absolutely.
I do think there's a pretty strong link between English lit, philosophy, critical theory, the ability to teach well and adapt materials for different audiences, but especially adapting them to teach well, which is
Mhm.
different from just information.
Yeah, absolutely. Wow, that's awesome. Um, we'll get into a few questions about the McMaster Optimal Aging Portal, if that's all right. So for the first one, there is kind of a few studies that are included in evidence summaries that seem to be like really actionable. But what criteria does the McMaster Optimal Aging Portal use to determine whether a study is included in this evidence summary?
So, as some of your audience may know, McMaster was sort of one of the homes of evidence-based medicine, and we're quite fortunate to have several of my colleagues leading different databases that all have slightly different approaches to taking primary articles or resources and filtering them down using best practices in evidence. So, my colleague Alfonso Iorio, who's head of the Health Information Research Unit, they take a subset of the highest quality journals across all of the fields of medicine They then look for those articles which have a high degree of methodological rigor, randomized control trials, meta-analyses, and systematic reviews. And they then filter those down for the top articles, which we will eventually use within the McMaster Optimal Aging Portal for blog posts and evidence summaries. On the public health landscape,
Mhm.
Maureen Dobbins and her team at Health Evidence, they provide systematic reviews related to public health topics, and those are also used in the creation of blog posts and evidence summaries. And then my colleague John Lavis, who leads the social systems evidence and health systems evidence through the McMaster Forum, he focuses on documents that are more aligned with policy and geared towards policymakers, but again, rating them, looking for systematic reviews or policy briefings that are based on the highest quality evidence. The fourth arm is the arm that I lead that focuses more on the development of what we call enhanced multimedia content. So this would be video posts, which are blog posts based around videos, or multimedia e-learning lessons that are sort of distilled. So each one has a slightly different focus, but they all use kind of a evidence hierarchy. And so that's the level of content that then gets adapted or translated for the general public on the portal in different formats, such as blog posts, video posts, evidence summaries, and e-learning and videos.
Oh, that's amazing. So it really is a team effort then, kind of
Very
getting
much.
all of the research and
Yeah.
really making sure it's translatable and geared towards the public in the end as well, so that really people can put the research into action. That's great. There is a wide range of topics that's covered by the portal, with options to search or browse via the Age Well challenge areas. Are there any challenge areas or topics you believe to be a little bit more important or the best ones to start with for people who are new to the portal?
Yeah, that's a interesting question. I think probably for things to be most engaging, it makes sense for people to have to start with a topic that interests them
Mhm.
personally, something that they care about with respect to their own health or a loved one that they're caring for or just interested in helping. What we find interestingly is fewer people sort of browse or search the portal than we anticipated. Many people become sort of free subscribers, which means they receive a weekly email with all of the updated content because the portal, just as new high quality evidence or studies are produced, the portal is a continuously updated resource. So every week there is a new email that subscribers receive where any of the newly published content is sort of served up and summarized in their inbox. So we find that most people look at the weekly email and peruse it for the topic that I guess resonates the most with them. Sometimes people are just interested in a topic, but when we ask people after they've reviewed them, there's often some personal angle on it.
Yeah.
What we would generally find is that a lot of the topics. There's probably two main topic areas that people seem most interested in. Some are practical ones related to how can they stay healthy. So how things related to walking speed or how to walk for their health or oral health. What are the important things to consider with respect to that? Also, topics related to driving or how to discontinue driving, how much protein and exercise one should have. So those sort of healthy living, kind of what are the best evidence practices around those. And then the other domain where we seem to have a lot of interest are topics related to cognitive health, dementia risk reduction, mild cognitive impairment, understanding dementia, or again, what can be done to reduce risk or prevent certain health conditions from happening.
Absolutely. Wow. So I would say then the best thing to do would be to subscribe and kind of keep kind of listening or learning
I,
more
I
as
I would agree.
things
I
come
think
up.
if you're a first time visitor, have a look at what, the latest things are on the homepage. See if a
Mhm.
topic grabs your interest. Otherwise, you could drill down through browser search for a topic of interest. And
Absolutely.
there may be folks who have different preferences with respect to
Mhm.
the format as well. So the blog posts and evidence summaries tend to be text only.
Mhm.
For those who kind of enjoy videos or multimedia content, the video posts or e-learning may be more up their alley.
Yeah, that's great. Kind of making sure that there's something for everyone. So no matter who you are, there's something you can kind of learn and a preferred way to learn as well is available to them.
Mhm.
That's great. Um, Next, who are the e-learning lessons mainly directed to? In the sense of, is there a population that uses these lessons the most, or do you find that it's maybe aging adults going through these, or even they're going through it with a loved one, or if it's a loved one themselves, or a care partner? Do you have
Yeah.
any kind of information on who accesses the most?
Yeah, so I would say the majority of users are between the ages of 65 and 85,
Okay.
and they tend to be more female users than male users
Mhm.
who go through the e-learning, or at least the ones who fill out post e-learning surveys. So we're extrapolating a little bit from who we get surveys from. I imagine there are probably some higher proportion of folks who go through, but we don't necessarily know all that much about people unless they tell us through the survey. But a very large portion of older adults, predominantly female, some of them are identifying as care partners for a spouse,
Mhm.
or in some cases, if they're a bit younger, they may be a child care partner. We do also get a range of other people who identify in different roles in some of our surveys. So there are some people who are healthcare providers or trainees. So there is a range of different people who go through, but the majority seem to be older women
Mhm.
and some in the care partner role, some just looking for the education and information for themselves.
Yeah. Wonderful. It's quite interesting to think about it. I wouldn't have necessarily thought at first either that there would be more women potentially looking at or at least filling the post surveys if that's the case. But it's
Yeah, it's
great.
in some cases for some of the lessons, the percentage of women is sort of 70 to 80%. So
Wow.
it is a higher percentage of those who fill out the surveys.
Mhm.
But we do get, data when people answer. There are certainly men going through it
Yeah.
as well. I think what's interesting, going back about a decade ago, I think a lot of researchers seemed skeptical about older adults, using internet-based learning. But actually, for more than a decade, the highest growth population of people using the internet and using the internet for health
Mhm.
information has in fact been older adults. And so we do see a lot of folks, even, over 75, even over 85, accessing the portal, and we get, great feedback from them
Yeah.
on the impact. So older adults are using the internet, and so think about that in the how you design your content for
Yeah.
people.
Absolutely. Right. In terms of kind of the e-learning modules and evidence summaries. Are there any that are really accessed more so than the others? And what does this potentially indicate about public information needs?
So it's sort of similar to the advice I was saying to you before about what types of content would should people go to or what
Mhm.
they access. There definitely seems to be a fair amount of interest in content related to cognitive health, and I think some of that has to do with the older audience demographic that is one of our primary audiences.
Mhm.
Some of it will depend on particular other grants that we're able to secure that
Mhm.
may involve a particular topic area. So, for example, we received some funding from the Public Health Agency of Canada to study and promote our dementia risk reduction e-learning. So that dementiarisk.ca project, we did a large randomized control trial with it, funded by the Public Health Agency of Canada. And then we also had some funding to promote that to a broader group of Canadians through digital media marketing and webinars and in-person presentations. So sometimes that skews the data a little bit if we
Mhm.
have opportunities to promote content, but by and large, there has been an interest with respect to e-learning on topics related to cognitive health, mental health. So we have
Mhm.
content on depression and anxiety, as well as other topics like driving cessation, like
Mhm.
when to retire from driving, also around mobility, walking speed, how to exercise if you have osteoarthritis of the
Mhm.
knee or hip, and other topics like social isolation. So a broad array, but there seems to be a little bit more interest, I'd say, in cognitive health, mental health, and mobility.
Mhm.
With respect to the blog posts and the video posts on or evidence summaries, we find that again, it's driven a little bit more by which topics might get featured in the weekly email alert. Sometimes we do get topics that are popular, and so maybe they're in the news more. We
Mhm.
had a webinar and a video post on the use of the shingles vaccine to prevent
Mhm.
dementia, and that was very popular in terms of our webinar format as well as subsequent videos. But otherwise, the evidence summaries and blog posts tend to be more what's promoted in the weekly alert.
Wonderful. And then just making me think of if there are ever updates to any, or you find that potentially a post previously that was really popular should be sent out again. Do things ever get updated and resent out via the weekly kind of emails, or is it always
Yes.
just something new?
Yeah, no, we have a bit of a systematic approach whereby we do review content periodically, and if there's been like key updates in the field, maybe new evidence, new guidelines, then we'll often review and update the post and may republish it with the updated information. In other cases, the content may still be valid, but it is a challenge with hundreds of thousands of articles out there and a significant number of blog posts. We sort of have to set a bit of a schedule about when they
Mhm.
can be reviewed and which ones merit republishing based on new evidence.
Oh, awesome. Right. And then kind of thinking about impact wise, what has been the impact of the McMaster Optimal Aging Portal? And then have you guys kind of researched or conducted research to quantify or qualify the impact that it has had?
So we've done a few different types of research. We started out in the beginning after launching doing more qualitative methods where we would sort of get usability feedback from our target audiences around the different formats and what they thought about how they were structured. And that became iteratively helped to improve the structure and format of some of the content that we provide. So, for example, we used to have at the bottom of every blog post a little bottom line summary, and users gave us feedback and said, actually, it'd be great to see the bottom line up at the top, so we know what we're getting into, and can
Mhm.
so we make iterative improvements based on user feedback all the time. So we did publish a series of user testing or usability
Mhm.
studies in the beginning. My colleague Maureen Dobbins and her colleague Sarah Neal Stramko have done sort of focused work looking at different types of offerings and what the blog posts that have been curated, the impact that they can have on people's physical activity and mobility. Where we've had funding, our team has also been able to study things a little more rigorously with, for example, as I said, the randomized control trial
Mhm.
of the dementia risk resource. And that showed that a 30-minute e-learning lesson was able to improve knowledge of dementia risk factors, improve behavioral intentions, and actually it even increased leisure time physical activity. And those changes were sustained after the end of the study.
Mhm.
We, on most of our content now, we have sort of a post content survey that people can opt into. And we use a validated tool to assess the relevance of the content, its understandability, whether people will use it, and whether they think they will benefit from it. And in the case of most of the e-learning lessons, we've got a fair amount of data and have published sort of descriptive studies around those evaluations. And for all of the pieces of content, we've really shown impact from that standpoint. It is,
Mhm.
again, more like a self-report. So we have not yet had the resources to kind of follow people up with objective findings, but we're in the process of writing up grants for particular content to look at that.
That's wonderful. Perfect. Moving on a little bit from the McMaster Optimal Aging Portal, I'd like to talk a little bit about the iGeriCare platform. So first, what inspired the creation of the platform?
So I would say it was very much inspired by my colleague, Dr. Richard Stramko, and I. We had a vision to improve the education of family friend care partners of living with dementia to try to help meet a clinical challenge. There's a lot to know and understand about dementia, and for family friend care partners as well as patients, there's rarely enough time in the clinical encounter. Though Richard, as a geriatrician, myself as a psychiatrist, we tend to spend quite a lot of time with patients. Many other colleagues in family medicine, internal medicine, neurology, they don't necessarily have that same time to spend educating family. You may have family that aren't able to attend the appointment, or
Mhm.
there's just you're rushed at the end of the appointment. So our goal was to provide, if people could sit down and talk with us and we could explain all of these different key things related to brain health and dementia. Our goal was to try and capture that in these educationally designed e-learning lessons, and the hope: improve the education of family friend care partners, improve the quality of care by this
Mhm.
improved education, and actually help care providers as well, because it helps
Mhm.
them, in the teaching and the education of patients and families while alleviating some of that time burden of doing that. So those are really our vision around it.
Oh, sweet. I can assume that probably there can be a lot of stress associated with being a care partner as well, and potentially not knowing and having to look for information. So having a platform that's really readily available can really be of help to kind of find little aspects and kind of improve and make sure that you feel confident about the care that you're potentially giving to a loved one as a care partner.
Yeah, absolutely. I think there's been quite a lot of studies that show that being a family friend care partner of someone living with dementia is one of the more stressful care
Mhm.
partner roles. And I think you're also correct that there is so much information, misinformation. There are a lot of excellent support groups, but sometimes that can feel a bit overwhelming
Mhm.
at the same time. So our goal was really to try to design something that was pretty simple, not too overwhelming,
Mhm.
not too much information, and presented in a way that would alleviate some of the distress, improve some of the understanding, and we have had very positive feedback in that regard. So I think yeah, it's there's nothing easy about it, but
Mhm.
I think this families have found this to be very helpful. And you know the some people do not have access to specialists, to
Mhm.
reliable health information. You know, it's not in some jurisdictions, it's easier than others to get a referral to a geriatrician or a neurologist or a geriatric psychiatrist. But if you don't have access to that, this is a way you can get kind of trusted, credible, accessible
Mhm.
education on the topics.
Wonderful. Now, similar to the McMaster Optimal Aging Portal, iGeriCare as a platform has a wide variety of lessons, kind of resources, and videos. Um, is this platform more often accessed for any of these, either like the lessons, the resources, or the videos? And then how may this also further inform potential updates to the platform?
We find the lessons, there's 12, I think there's 13 now, 13 sort of core multimedia e-learning lessons. I would describe those as being far and away the most accessed elements. And, you know, the idea here was always, especially if you were working with a clinician or if you were
Mhm.
self-directed, is that you could just bite off the area that was of most relevance to you. So if you've just had a diagnosis of mild cognitive impairment or you're concerned about that, you can just do the lesson on what is mild cognitive impairment. If there's been a recent diagnosis of dementia and you don't understand a lot of the foundations of it, then what is dementia is a good starting point.
Mhm.
But many people struggle. Maybe they have a family or a family member who has what we call responsive behaviors or behavioral expressions, where they're having different behavioral or psychological symptoms related to the dementia. And we have lessons that cover those topics as well. So I think there is a range of core topics in the lessons, and that tends to be either what clinicians refer their patients for, we call it like an educational prescription,
Mhm.
or what people in a self-directed way, they're like, okay, this is most relevant to me at this time. They might come back later and go through a different lesson. The videos were designed to be a bit of an extension and a more in-depth exploration of some of the core topics, as well as, you know, important ancillary or adjunctive topics. So a
Mhm.
deeper dive on a subtype of dementia like vascular dementia, or a deeper dive on the relationship between hearing and dementia, or driving and dementia. So we often would have guest experts, or Dr. Stramko and I
Mhm.
would focus on a particular topic and do kind of a 45-minute deep dive on that.
Wonderful. Right. Um, Now, I don't know personally or from potential things that you've heard, are there any of the lessons, resources, or videos that do stick out to you a bit more or that you think of more often than others?
I think it's probably the combo that I just mentioned for
Yeah.
people at the early stage of either cognitive concerns. it's probably the what is dementia or what is mild cognitive impairment. Mild cognitive impairment is obviously there are gaps in the public's knowledge of dementia. I think mild cognitive impairment is probably a condition that even fewer people are aware of, but it is arguably of equal importance because
Mhm.
if people can get an earlier diagnosis, they may actually reduce their risk of progression to dementia. And then conversely, at the other end of the spectrum, when people have more moderately advanced dementia, that's when we're seeing maybe more uptake of the e-learning lessons related to apathy, depression, anxiety, or those responsive behaviors. We also have a newer lesson that we did in collaboration with a colleague who's a speech language pathologist on
Mhm.
swallowing difficulties in dementia, and that again a little more specialized, but actually many people living with dementia do
Mhm.
have important swallowing difficulties or dysphagia. So that there's a role for the different lessons, and there's an important one on caregiver wellness as well, because as you mentioned, a lot of just stress, anxiety in that family friend care partner role. So that's one to kind of give people permission to look after themselves as well.
Mhm. Good. Perfect. Um, Additionally, how can like users feel comfortable that the information in iGeriCare additionally is kind of current and evidence-based? Is it a bit similar to kind of how you explained with the McMaster Optimal Aging Portal again?
Yeah, I think both Dr. Stramko and I are practicing clinicians in the
Mhm.
field, so we're alert to changes in major guidelines or new developments. It does remain a bit of a challenge. There's been a lot of recent advances within some of the more complex concepts like biomarkers for
Mhm.
Alzheimer's disease and the availability of, or at least the approval of some of these disease modifying therapies that are, quite expensive and not necessarily readily available, require. So we are looking at making updates, but again, we periodically review all of the e-learning lessons on the site. We make iterative updates and improvements.
Mhm.
And it's a challenge or a balancing act too, because we're also trying to keep the information understandable, not overwhelming. And so where you have like emerging areas that are not necessarily well established in practice or readily available in clinical care across, the country, we just have to be mindful of the timing of updating content.
Yes.
So we try to keep things at the level of, what are best practices and
Mhm.
most commonly available, but we do have a process for reviewing it, ensuring that the content remains evidence-based and understandable.
Wonderful. Now, kind of going along with kind of the current and evidence-based aspect of it, in the past or kind of currently, people have potentially been worrying about if the information online is trustworthy, accessible, or useful. So, as kind of somebody who's really developed some platforms that are great and are evidence-based and current, what have you learned about how to design those digital health education or platforms?
So I think, there's a big difference between just information online and educationally designed information. So I think that's an important distinction. Just putting, health information, obviously, some health information more credible than others and, better written. But there is still a difference between information on the page versus content that has been deliberately designed to improve people's understanding and learning. So I think that that is a big gap, and
Mhm.
it's it's not easy to develop e-learning that conforms to best practices because
Mhm.
there are actually there's a whole science of how to design multimedia e-learning. So those are the kinds of things that our team incorporates into the e-learning, but it's quite
Mhm.
time and labor intensive. And I'm
Yeah.
very fortunate to work with a great team of people
Mhm.
within our division of e-learning at McMaster who have a lot of experience in that. But yeah, you're competing against an information ecosystem that is
Mhm.
rife with bad information, misinformation, deliberate disinformation. And I think we're likely going to see more of that because with generative AI tools, it's
Oh.
relatively easy to create not just textual information, misinformation, or
Mhm.
disinformation, but now increasingly creating multimedia and videos. So, having uh, people need to have some trust in the organization, institutions that the information or education is coming from. And hopefully there's, some range of high quality human in the loop so that the information and educational content is coming from best evidence. There's also an expert human in the loop that is reviewing this to ensure that it's not just based on best practices, but
Mhm.
is meaningfully designed for helping people to understand the information.
Absolutely. I think meaning, like it being meaningful is truly kind of a good aspect of it too. I think it's interesting to think that some might believe that it takes less work or that it's not as complicated to put together kind of these platforms, but it really is considering, like you've mentioned, that the information should be current. It's really finding between the misinformation and the proper information, making sure it's evidence-based, and then always kind of going back over everything and making sure that things are kept current, and with the current best practices.
And I think, in the history of evidence-based medicine too, there's a hierarchy of evidence and the quality of studies that are included, but it's also very important that people's values and preferences are
Yes.
part of the kind of what makes it meaningful.
Mhm.
So it's important in terms of the human in the loop who is providing some interpretation
Yeah.
about the best evidence content to help people frame it around like their own values and preferences as well. So, the when we're designing the education, we can't necessarily say, well, it's for people with this value or these preferences,
Mhm.
but we can present the information in a way that we're interpreting the best evidence, we're designing it for how people learn, and we are appreciating that values and preferences are very important with respect to the education and the information.
Absolutely. And I know with some of what you've mentioned earlier too, just in terms of listening to the public, listening to feedback based off of what might be better for the platform or little improvements that could be made, even just in terms of accessibility. I think that's wonderful and really keeping really in mind the public and considering who is accessing the platform
Mm.
and shaping it for those individuals. Oh. I just have one kind of last question, but do you have any main messages or key takeaways that you'd like for the public, current researchers, or even student or future researchers to know?
Well, I think one thing is a lot of people sometimes think if you build it, they will come. Producing good resources or good content is not in and of itself a knowledge mobilization strategy. So, it's great for people to who have expertise to become involved in improving the information, especially the health information that's out there. But the producing it, putting stuff on a website that is not necessarily knowledge mobilization. And it remains a challenge to reach people because there's so much information out there. Sort of making a headway in the space is
Mm,
tough. And then I think, information is not education. So designing educational resources does involve a particular type of expertise around that. It's definitely not going to be a one size fits all.
mm,
The other thing we haven't really talked about is sort of access and equity. So there are some, populations that are challenging or maybe impossible to reach with online health information, at
mm.
least in some forms. But that I wouldn't want to overestimate that, but I think it's just an important thing to keep in mind. Um,
Absolutely.
Linguistic barriers, cultural barriers, other social determinants of health that may
Mm,
interfere. So this is not a panacea for improving the health literacy of every single Canadian, but it does have a certain reach that is
mm,
attractive, and it's one of the things that I do enjoy about the work is the ability to scale it, and not a perfect solution. And I
mm.
think often, working. I guess the other tip for researchers, clinicians around knowledge mobilization is it's good to think broadly but act locally.
Mm,
Getting things at point of care that will be impactful for clinicians working with their patients. It's one of the things that's very satisfying about the iGeriCare intervention, or the dementia risk, where we're seeing um, clinicians using some of these tools sort of at the bedside with patients. Yeah, it's always I always enjoy it when I'm reading the clinical notes and somebody says, "Oh, and I recommended the understandingdelirium.ca e-learning for the family." So
mm.
those things I think are really important to encourage that local uptake, and
Yes.
great if it has value, outside that for other people. But that's probably one of the tips I would say is, think global, act local.
Absolutely. I think it's great. Really kind of knowing that what you're doing is having an impact more on a personal level. Just
Mm.
every other person kind of who can look at that information and be helped by that information is one more person helped. It's one more person who might feel more comfortable caring for their loved one or something like that. So I think that's really great to
I,
hear.
I think, it was interesting. I was thinking about it with some of the studies. We were able to do another randomized trial of our resources related to depression
Mhm.
and anxiety, and we used validated measures of depression, literacy, anxiety, literacy, and stigma. And, there were improvements in knowledge, reductions in stigma, particularly for those who had lower levels of prior knowledge or higher levels of stigma. And again, it may be quite challenging to reach those people because they might not be interested in the topic for a reason. But the differences that you can make, even for some of these things, the increase in knowledge or decrease in stigma might not be a huge difference.
Mhm.
But the fact that you could scale this up and reach so many people, I think these are quite potentially helpful public health interventions. And, within our healthcare system, the more we can improve knowledge to improve, self-management or prevention, the more, I think that we could really benefit to try to do a better job at patient self-management, or reduce some of the impact on the healthcare system and have a healthier population ultimately.
Absolutely. And I think, like you've mentioned previously as well, that you won't be able to reach everyone. There are kind of pockets of people who are more difficult to reach. But it is important to keep in mind, again, like
Yes.
you said, all of those populations and knowing that if you are kind of introducing something for a specific population, making sure that potential future interventions or research is going or is geared towards the populations that have been missed at that point to make sure that it really does end up being equitable and that everybody kind of has the same access to the care and to the information.
Yeah, and in some cases where we've done, randomized trials,
Mhm.
our next step is to try to have a more deliberate recruitment strategy to look at for newcomer Canadians or
Mhm.
those with lower levels of prior education, do these interventions have a similar impact? Might be greater, just like we've seen in some of our studies where those with lower levels of education actually benefited more. But
Mhm.
again, that's the kind of thing that's good to study more systematically rather than just based on sub-analyses. So,
Mhm. Wonderful. Well, those were all the questions I had for you today. So I just wanted to say thank you very much for taking the time out of your day and really showing up, talking to us about all of your expertise and knowledge on the McMaster Optimal Aging Portal, iGeriCare, and beyond. But yes, thank you so
yeah.
much. It really was a pleasure meeting you as well.
Likewise, thanks very much for having me.
Awesome. Thank you very much.